Oh, no music. Let's just dance.
No music. Oh, there it is.
That's a lot of bass. I loved it.
That was a lot. Thanks for taking us back to the 70s there, Brad.
Oh my
Yeah.
God.
Hey, no, it actually kind of goes with our podcast title today, actually.
Oh, does it? What's the title of the podcast
Title
today?
of our podcast today is Dazed and Confused. So we're going to talk about lots of things related to patients' ability to make their own decisions when we're doing assessment, whether it's an AMA or if they can just make their own decisions. So we're going to talk about competency, capacity, and then we're going to kind of touch on power of attorney type stuff.
So with today being 420 and also your birthday just a little bit later in the day from our previous podcast,
Yeah.
are you going to be able to practice this later because you're going to be dazed and confused, and then
I
you
will
might be able
not.
to practice capacity,
Yeah.
all that kind of stuff?
I
Or am
actually
I
will be
wrong
able to
topic?
meet capacity and competency because I will not partake. However, many people do.
Oh.
And right on. Thanks for celebrating my birthday.
Happy birthday.
Yeah.
On that note, no, you know, I mean, I think Dazed and Confused, you're right. It's a good title for this topic today because, um, you know, in EMT school and in medic school, we drill into students so much, like, you know, between consent and implied consent and you know, who's alert and oriented, who's not, who's allowed to refuse care, who's not. Um, and there's an awful lot of gray area.
Absolutely.
And you know, and you're talking about the difference between, you know, kidnapping somebody and not. So I mean, I think there's kind of a big discussion piece there, and I think hopefully today we can clear some of that up. Some of it still might be a little gray because I think a lot of this, much like EMS in general, lives in the gray. But hopefully we can provide a little bit of clarity. Having a social worker on board today to help provide some
definitely.
of that clarity, I think is going to be pretty important. So where do you want to start there,
Yeah.
Ms. Birthday Girl Jalen?
I think it's something to kind of important to touch on when we talk about consent. Consent is important, but we have that gray area of implied consent when our patients aren't able to answer questions appropriately, if they're a minor, kind of some of those gray areas where we're like, what do we do? What do we not do? Um, and one thing that we do need to remember is that adults have a choice to make their own medical decisions. You know, if somebody is, you know, over the age of 18, not on any kind of conservatorship, not on any where they're able to make their own medical decisions, whether they have power of attorney, someone else has power of attorney, we need to determine that, or if they have some type of disability to the extent that they're unable to make those decisions. And we will talk about that a little bit later, but people have the autonomy to make choices for their own selves. And so we do need to remember that. And we definitely don't want to kidnap because, you know, there are times where we might call it in and be told that we need to have SO on scene to put them on a hold and transport them when that doesn't meet the criteria.
Well, and, you know what? I think that has been the instance that's happened a number of times, at least here locally, where, you know, we're calling our medics are calling to document an AMA, at least get some base hospital buy off on an AMA, and base hospital doesn't buy off on the AMA, and so it kind of puts some people in a sticky situation. I think there's three big key terms that are pertinent to what we're talking about. The first one you already described, right, is autonomy, right? We all have the right to make our own decisions regarding the right to make our own decisions for our body, right? That autonomy. But what we're starting to describe now, in addition to that autonomy, is the capacity, and that's that functional determination that an individual is or is not capable of making that medical decision given a specific circumstance or a given situation. And then that leads into the competency side of it. You know, it's the ability for an individual to participate in legal proceedings. Right. And so there's kind of three different but related topics or concepts that all kind of run commonly together with this.
No, you're absolutely correct. And some of that key takeaway, and I know it sounds very like still gray area, but you have to, when you're explaining information, or they're getting information from a patient, they may be able to answer all those questions. We have to decide and use some discernment is like, are they fully understanding the consequences of what of the decision process making processes that they're going through, even though that they can answer the questions appropriately. And that's what capacity comes about. Yeah, they're answering all the questions, but do they fully understand what the consequences are, and are they making the best judgment for themselves at that time? Whereas we talk
Sure.
about competency, that can fall into a little bit of the legal realm in the sense of, are they able to make, their own decisions because someone else has power of attorney or they're under conservatorship. And we may not know that. And that's kind of a bigger picture that we may not be able to get into because that's a whole other caveat to it. But usually that's more long term, like they know what, they can reasonably make those decisions when we talk. They answer our A no questions and then they can make decisions for themselves. And that makes a reasonable sense to uh, anyone, like anyone else that would answer this, get asked the same thing or make those same decisions.
So when we're talking about the capacity to make a decision, our medics have to make some distinction when they're in front of a patient. Hey, are they actually, do they have the capacity to make these decisions? And so there's kind of a couple key concepts that I wanted to throw at you, kind of get your thoughts on it. And these are actually kind of out of our ISMA protocol, which has been updated to reflect some of this discussion that we're having. First one, individual has decision-making capacity if, number one, is oriented to person, place, time, and purpose. A&O by 4, I think most of our medics are pretty clear about that. As soon as they're not person, place, time, and purpose, most people are pretty good about kind of understanding, maybe this person's not, they don't have the capacity to make those decisions.
Yeah.
Number 2, that they're capable of understanding the nature and the consequences of the proposed treatment and the refusal of such. And so, I mean, I think that one requires some assessment on its own, right?
Yeah.
How do we specifically? I mean, from your aspect, how would we specifically determine that they're understanding the nature and the consequence of the treatment or the refusal too? What are your thoughts on it?
I think I have a few thoughts on that actually. First thought would be like
Shocking.
if you were to ask any other patient those same types of questions to understand their capability of understanding and making the appropriate decisions, that they would make the same, if not very similar decisions that this particular patient in question is asking. That it would be one aspect of it.
Okay.
I mean, one example that comes into my mind, and it's a very easy example to show black and white, because I know things are not always going to be black and white, would be our E2O patients, our alcoholic patients that are drunk. They went and had a good time, and they can answer all your questions. They just want to be left alone. Maybe they fell or something like that. Very minor abrasions, and they're answering all your questions properly. They do not want to go. And they understand and are able to make those same decisions, where we were to ask anyone else these same questions, and maybe even some people who have actually had some alcohol intake as well, that are absolutely refusing, that they want to stay home. Now, I would add a few other things on there to add some safety, because that's the aspect of it, is not only are we
Right.
leaving them there, that they're capable of making those decisions, but are we leaving them in a safe manner? That plays another factor into that.
So I mean, it sounds like a lot of this plays into AMAs in general in terms of refusing transport.
Yeah.
But I'm assuming kind of the same thing would apply to any suggested treatment as well.
Correct. Yeah. Because, patients have a right, again, that goes back to autonomy, to say, I don't want this treatment. I'll take this treatment, or I'll get transported, but I don't want this.
So what are some ways that our medics can it can accurately reflect and document that conversation that they have with the patient, so that they're providing full and complete documentation, that they appropriately relay this to the patient? I know, I mean, I'm thinking, like, they can have a very frank and honest conversation with the patient, like, hey, repeat back to me what I just said, right? What is going to happen to you if you, and ask them the open-ended question, what's
Yeah.
going to happen to you if you don't get transported? And I mean, would that be a way for them to kind of document that?
I think that is actually one perfect way to document that. And, if you're having that same conversation of asking repeatedly, of like, hey, are you sure before I give this that this is what you want? And document that as such so that there's been multiple incidents where you asked, you got the same answer. And so that you have at least attempted more than once and saying, yep, we advised you of all the consequences. If you don't do this, this could happen. You're good? Okay, bye. Like that
Got it.
very broad thing. So just kind of reintroducing that. Are you sure? Um, I don't feel comfortable with this. However, or what I suggest is this, and you should never use fear mongering. That's not a good way to get consent from people, is either. Um,
Sure.
but definitely having that conversation of like, okay, are you sure? I won't give this medication. I kind of recommend it. Whatever it is that that medication is for a better outcome.
So I had a question kind of on that same realm. So how do you document a capacity assessment in a way that protects both the patient, yourself, and if it's later scrutinized by any way, shape, or form?
I was always a proponent of, and I don't think there's one clear way, and you can jump in here as well, but that repeated, that open and clear conversation. This is specifically what I asked. I asked it multiple times, and each time the patient stated this. The patient was advised of all consequences on, such and such, such and such times, and it might even be beneficial to like timestamp that. Like I asked initially
Right.
at this time, then repeated asked this time, patient still denied. However, that looks like, just so that it's very clear that that conversation was had multiple times, and I would even say the patient is alert to person, place, or time. However, such and such was a factor, whether it's they chose not to have a treatment or there was something like a hypoglycemia or something where we kind of factor in some of that capacity aspect of it. And we can say, yes, it was corrected, or no, even though they're answering these things, this is what we're concerned about. And they understood.
Because I mean, really, who this is applying to, right? I mean, this is applying to people that if the patient is altered, it's no longer a question of capacity and
Correct.
competency. They're
Right.
altered. They don't have that. This is really for people, and Jalen, I think you already pointed out, these are alert and oriented patients that are not making that we deem to be not making appropriate decisions. People are allowed to make all sorts of decisions for themselves, but
Yeah.
this is really how we are documenting, I think to Brad's point, right? How we are documenting the fact that we are leaving somebody who is alert and oriented, either letting them make a very poor decision. Again, in our view, everybody gets to make their own, but
Yeah.
from a medical standpoint, not the suggested treatment. And this really doesn't have to do with the altered patient. As soon as the patient's altered, it's kind of cut and dry. They're not going to meet
Right.
Right.
the criteria. This is really for those alert and oriented patients that we need to determine. And I think, man, that drunk patients, right, is probably the most common one that anybody comes across. Is yes, they're drunk. Do they? But they're alert and oriented. Do they have the capacity to understand what is going on? And I think just that factual documentation, to Brad's point, right, is factual documentation, witnesses, get family involved,
Absolutely.
get neighbors involved, get multiple people involved. Um, so that that they either can help the patient make the right medical suggested decision, or if nothing else, we've CYA'd that these conversations have taken place.
Yeah, witnesses are pretty big, and that adds a level of safety for the patient in the sense of we're
Oh
not
yeah,
just saying, "Bye, see you later, good luck on your
yeah.
own," and there's no follow-up with that. By having bystanders, family members, somebody else that can kinda take over like, "Hey, I'm gonna be here with them, and so
Yeah.
we'll call back if they need to change or we'll take them to the hospital."
I mean, that's kind of like AMAing the diabetic, the low blood sugar
Mhm.
after you've made them a sandwich and gotten them all back, is not leaving them alone,
Yeah.
making
Mhm.
sure that they're in a safe place, that should the symptoms reappear, they have an ability to either activate the 911 system again, or somehow seek some treatment, and not just gonna be alone in their house.
Yeah.
Do you think sometimes maybe we are too quick to label disagreement as incompetence?
Ooh,
Where the
I
patient's
think
disagreeing with our treatment, and those paramedics may be mistaking that as they're incompetent, they're not understanding what's going on, but they're just truly disagreeing with the treatment path or the transport, or their understanding of why we're there.
I mean, I think that definitely happens. I mean, especially if you have a particularly sick patient in front of you. I mean, like somebody um, that you know is sick. This takes me back to my internship when I remember on internship, we made a STEMI from his house, and we were on scene for probably 45 minutes or an hour. SO was there, multiple conversations with the base physician, and then he was very clearly able to articulate he understands what's going on. He doesn't want to go to the hospital. I understand that I very well could die. He verbalized back all of these things, and I think unintentionally we showed a good case of capacity. This was before this was a big discussion, but I think he demonstrated all those pieces to it. Obviously, we vehemently disagreed with the treatment. I mean, it's star 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 STEMI. Of course, you're going to the hospital, and he proved to us that that's not necessarily true. And I think it's important for us all as providers to make sure that we don't let our personal bias, what we do think or don't think needs to happen. I mean, flip the other way around. How many times do we take somebody to a hospital that probably doesn't need to go, right?
Right.
And so it kind of does work both ways, and I think our personal bias probably plays a lot into that.
I would probably agree. I think the other aspect of that would be provider dependent is that level of educational piece, because sometimes fear outweighs judgment. And when we
Mm,
talk about capacity as
interesting.
well. And so if we can, as appropriately as we can, say, hey, we're going, because it might be more of a particular hospital than anything else that they're afraid to go to. That we just have that, educational piece of it too, so that we can lower the risk of their fear as much as we possibly can. I'm not saying force people to go to the hospital. That is not what I'm trying to
Right,
say.
right,
But
right,
like, there's
right.
that level of communication that can happen of like, hey, and I'm sure you had it with that STEMI patient. They were
Oh
probably
yeah,
still adamant, and you will run across those patients. But sometimes it's as easy as like, hey, this is what's going on, this is what I
yeah.
recommend. And if I were you, I would totally go, or whatever that looks like, to get that done. And if they're still absolutely, absolutely not, then you do the best you can. And
Well, and I think the other piece to that is how we communicate with the patient, right?
yeah,
We have to be careful with the medicalese. We have to speak in very straightforward terms.
yeah,
Obviously, and here we're referencing STEMIs and whatnot, but your average patient probably is not going to understand specifically what that STEMI is. So
right.
using clear text, using clear communication, and not talking down to a patient, just giving them very clear, sir, you are having a heart attack.
Right.
Whatever that looks like. And just being a little bit, just making sure choosing our words carefully,
Yeah.
so we don't have to resort to a carrot or the stick kind of a moment, but just being very clear of what the risks and complications are, and up to and including death, right? That whole AMA spiel
Yeah.
that we practice so much, but making sure that we're giving that spiel to the right person, I think is important.
Yeah. And I think that is beneficial to help. But I think you would do that to any and all of our patients, especially if we feel like they should go. Uh, we
Yeah.
do we do try to get them to go, but there is that those patients that go, absolutely not, no, thank you.
Well, and I guess here, at least locally, we have the assess and refer protocol now. So before it was either transport or AMA.
Yeah.
There wasn't really an in between, and now we have assess and refer, which is allowing a specific subset of patients that it's not an AMA, it's not a transport. We've assessed them and we're referring them to another level of care, whether that's urgent care, whatever that might be. So there is now an intermediary that really AMAs should be patients that we feel should go to the hospital and don't,
Yeah.
and they don't, and so yeah.
And for that assess and refer, does that mean they're going to their own private doctor, urgent care, kind of all of the above? They're doing it on
So
their own?
all the above. There are a couple key pieces to it, but there's only certain chief complaints that can be assessed and referred. Vital signs need to be normal, and then the big piece is that there has to be a treatment plan in place. And so there's a couple of criteria to that, but what we don't want to do is just let people go, oh, we're not taking you, have a good day.
Yeah.
So there's a treatment plan in place. It just may not necessarily include an emergency room.
Okay. Yeah.
So capacity, competency, all that.
Yeah.
Where should we go from here?
So with the capacity and competency, once we determine that a patient is making the right judgment for themselves and they
Sure.
either choose to go or not go, we can then follow what we want, either transport or get an AMA, whatever that looks like, assess and refer if that fits that criteria. But the other aspect of it that sometimes we run into, and in fact, I just ran into this we just had a discussion about this not too long ago, is our power of attorney patients. And that is when we
Mm,
go on a patient who does not make their own medical decisions. There's different levels of power of attorney. It could be just medical, it could be medical, legal, and financial, like whatever that looks like for that
mhm.
particular patient. You do need to make sure that it is clear of which one they have the power over. So if we're going to talk specifically about medical power of attorney, and so when a patient calls, or somebody calls for a particular patient and they don't make those decisions, and the patient's like, absolutely not, I don't want to go, um, you know, they don't really have a choice in that. I mean, it's better to get patient buy-in from that, but usually those patients have like had a history of dementia,
Sure.
Alzheimer's, something where they have not been able to make their medical decisions. It's not like just for you know people that like us, Ken and I talking right now. That's a little bit different. That's conservatorship, and that's a different legal aspect where they, depending on how severe the
Hmm.
conservatorship is, and it's not for you guys to like determine, but it can add a little wrench into that when a patient doesn't want to go. But sometimes you see that with the behavioral health aspect of that with the conservatorship, where they're just not able to make the best decisions for themselves, and so that kind of falls into that as well.
So, just so I understand, right? These are two different legal avenues that people fall into.
Correct.
Power of attorney sounds like chronic, likely to never get better. You referenced kind of the dementia, Alzheimer's kind of side,
Correct.
and so they're going to have a permanent power of attorney.
Yeah, that's more like think more like end of life type stuff. Just
Okay.
like an elderly population. Not that it couldn't happen with the younger population, but usually, something that's chronic
It
that
tends
way.
to be, sure.
Yeah.
And then you referenced the conservatorship, which sounds like it might be more temporary. It could be long term, but it could be for a period of time. And it sounds like that's almost more behavioral, bipolar, schizophrenia, whatever that kind of
Yeah,
looks like.
bipolar schizophrenia or some like gravely disabled patients. So they're
Mm,
above 18, but they have some type of disability whether it's cognitively, usually not physical, but that it might something where it affects the cognitive ability of patients to be able to make those decisions for themselves.
got it.
That can
Okay.
play a factor into that. So, when we talk about that, that's the disabled. You see it a lot with mental health. So, like your bipolars and schizophrenias that are so severe that they're unable to live independently or make their own decisions.
So, how do our medics navigate that?
Great question. Usually, that was not one of the top questions that get asked of like, "Hey, do you have power of attorney?" But that is a good question when you are talking to somebody, and it's better. This is a broad statement. You can always
Sure.
ask the patient, but you may not get a correct answer because there's still a level of autonomy that they're trying to instill in patients.
Sure.
Um, so that they have, a standard of living to live by and some
Sure.
independence, and that's important too. However, if you can ask a family member or if, whoever they live with, like who makes the medical decisions here, that's usually a good start. Sometimes the family members will go, "Hey, I have medical power of attorney." Like they'll come out and say it directly. It's just how educated the family is on those particular things, or know the importance of saying those types of phrases to us. So if we're suspecting that, we can ask. You might get some, you know, flack about that, some rudeness, but it is a question we should ask.
I mean, and it sounds like these are ones that you probably wouldn't ask every patient,
No.
but a targeted patient, whether this is probably a conversation if the patient is. As an example, maybe an elderly patient who doesn't want to go to the hospital, but probably should for
Yeah.
whatever medical complaint, and they go, "Well, I really don't want to go. I really don't want to go." Maybe that might be a time for somebody to be like, "Hey, family nearby, do you guys have are there any other people making medical decisions, or is it just the patient?"
Right.
It's probably not something that you're asking every patient, but especially if the patient is going down the route of "I don't want to go." We either need to figure out whether they're allowed to make that decision or not.
Correct. And it's specifically power of attorney. If you have dementia patients or known Alzheimer's patients, and if you're asking, "Hey, is this normal or what's different today than normal?" Might want to say, "Who makes the medical decisions here?" And there is paperwork that they can provide as well.
And so, I mean, I have to imagine that that's, uh, That's going to be most relevant on patients that are at that moment alert and oriented, right? Because again, once they're altered, that decision's already pretty clear. But a lot of our dementia, Alzheimer's patients have moments or days of significant clarity
Yeah.
and can be just fine. And then that's when understanding that somebody really is allowed to make those decisions a little bit more consistently is important.
Yeah, no, that's absolutely true. And usually for power of attorney, especially medical power of attorney, it's supposed to really align with what the patient has always wanted. It's like they've
Mm,
had the conversations with their loved ones.
hopefully.
Yeah, hopefully. And that's part of the process. And it's supposed to align whatever decisions are made are supposed to be what's not only in the best interest of the patient, but what the patient would have wanted if they're able to make those decisions. Sometimes we
Sure.
don't see that, but that's what the whole process of it is. And you're
Got
right.
him.
If we have our dementia patients or Alzheimer's patients where they're having to, clarity, and maybe they're just a little agitated, but nothing's different,
Hmm.
or they complained about something earlier and they don't want to go. Like that's where that falls into where we have to kind of ask those power of attorney questions. As maybe it's not a more altered than usual, but like this is what they're kind of complaining of and they're not wanting to change. And that could be normal. They may refuse a lot of things.
Sure.
So it's definitely not easy to navigate.
No, no. Well, I mean, because we want to respect everybody's bodily autonomy. We want to
Yeah.
make sure that from that whole from EMT school on, like if you take them there, that's kidnapping,
Yeah.
and I mean, certainly at some point it could it could get that far, but I think that's what everyone's kind of worried about, or at least nervous about,
Yeah.
and so making sure that that we're taking patients appropriately or not leaving patients inappropriately that really would benefit by going and being evaluated. Do you if you've got an elderly patient who does have a power of attorney that families on scene says, hey, I have power of attorney, do the medics need to take that with them? Do they need like, so we all know the post, right? The
Yeah.
bright pink paper sitting at the head of the patient. Those are we're pretty familiar with. When we're talking about power of attorneys, is that something that should necessarily go with the patient, or can it follow behind them? I mean, the post is always pretty clear, but power of attorney gets a little bit more legal than most of us are.
Yeah. Um, it depends.
Okay.
For the most part, no, but I do highly recommend that you document who the power of attorney was, that paperwork was actually provided. And then you could add any caveat of like what county it was issued from. Sometimes there's even expiration dates on them.
Oh,
So just
okay.
be mindful of that. But if we're talking about our chronic care, then you know, it's pretty long term. It
Right.
should follow, it can stay with the caregiver who has power of attorney that's locally
Okay.
and meet them at the hospital because there's additional stuff that needs to happen when we talk about hospitalization and who makes those decisions. And that is on the hospital side. And when we talk about power of attorney, some of that educational pieces, it should not be if we're in the state of California, in San Bernardino County, and power of attorney is in, New Jersey or somewhere that's far away, medical power of attorney may not be the best person. And that's again an
Hmm.
educational piece or something to think about when, as we get older and start having to enter that life stage of helping our parents out or whatever that looks like. But um,
Sure.
that can be more difficult because how do we figure out that that's who actually has power of attorney? How, do we know if it's actually legit? So that's where it gets a little bit more complicated. It does happen. I've seen it quite a bit when we talk about any kind of decisions, not just medical, just financial decisions and stuff like that. Is somebody who's not
Sure.
close and they're like, I'm not there. We're like, yeah, we know.
So, and again, I think to any of our students that are listening to this, I think the big takeaway on this, again, if your patient is already altered, right, they are not alert, unoriented to person, place, time, and event, time and purpose, however you want to word that. If they are not A&O by 4, uh, a lot of this discussion regarding who's allowed to make that transport decision goes away,
Yeah.
right? I mean, they're altered, so we're going to operate generally speaking under that implied consent, and the patient really doesn't have that capacity if they're in an altered state. Really, this gets down into the nitty gritty of they are answering our questions appropriately, but why they may not be allowed to make decisions for themselves. That's a pretty small subset of population,
Yeah.
but it certainly exists, and we certainly need to be prepared for it. Um, when there is lights going
Yeah.
on and off over there.
Gotta
Yeah.
move a little bit more.
I know.
So I mean, I think that's I don't want people to be hearing this conversation and think that this is most or many patients fall into this category. In fact, most don't. Altered patients are going to be altered. This is a very small subset of population that are alert and oriented, and we need to determine whether they're actually able or capable or legally allowed to be making the decisions for themselves.
No, you're absolutely agree. I think it's more important that we have the discussion so that if our patient or if our students are in that position where they're like, man, what do we do?
Yeah.
They could, at least have a little bit of an idea of, how they can navigate that, or maybe something to ask to rule out. But you're right, it's a small population.
And there's some fallbacks, right? I mean,
Yeah.
you can always fall back to a base hospital to have that conversation, and present the story, to present the situation, to present the mechanism, whatever that whole picture is, to fall back on that, and another, a physician to bounce it off of, right?
Hmm.
We all like the ability to bounce that off of a physician. And especially when we're all fighting for the same thing,
Right.
make sure the patient receives the care that is probably most appropriate for them. You can get law enforcement involved, right? You can get sheriffs or PD involved. However, and I saw your face on there. You wanna take care of that. However,
Yeah, that however part is there specific criteria. So when we talk about having sheriff's officer on there, on scene to be able to help us make decisions, yes, they can detain patients, but there has to be some type of, they can only detain them for so long, and then it is, they either have to be charged with a crime or let them go. And the other caveat is do they meet 5150 criteria? Because sometimes you might hear like, oh, can the officers put this patient on a 5150? And they're going to say, oh, because they're a danger to themselves. That's not exactly what that criteria means. When we talk about 5150 criteria, especially when we talk about harm to selves,
hmm
there needs to be a very specific plan in place, and they have to express, like, say, I already have this, I'm going to do this, tomorrow or Thursday, and there's nobody that's going to be able to stop me from doing that. And that also works for that same criteria when they talk about harm to others. Just because somebody is swinging at you, and wanting to fight you, that doesn't necessarily mean harm to others. Yes, there's harm to others, but not to the level of criteria, because there's usually a plan and a reason specific of why they're going after that particular person, not just because they want to be left alone. And so that's that weird criteria aspect. And there is
yeah.
also gravely disabled. And so it can meet some of that criteria, but it's very specific. Like, what does, gravely disabled,
And so I think, and this is the segue to it, is the PD is not the get out of jail free card, no pun intended, right?
Right.
I mean, it's they are able to assist with some patients, absolutely,
Yeah.
right? They are able to write some psychiatric holds if the patient meets enough criteria. Certainly something that we can't do.
Yeah.
So I mean, there certainly is an avenue there, but most police officers, certainly the ones that I've worked with in the past, aren't just going to willy-nilly write 5150s because we say, hey, can you put that person on hold? They need to meet specific criteria. So PD is a resource. Base hospital is a resource,
Yeah.
and feel free to utilize them. But PD is not just going to write holds because we ask them to.
Correct.
That would, in many cases, be an inappropriate use of that power, and we certainly want to avoid that if ever possible.
Yeah. No, I totally agree.
Um,
The only other thing I wanted to touch up on really
yeah, I was
quick
gonna, yeah,
is, when we were talking about power of attorney and how it's supposed to align with what the patient has wanted, or would make those decisions the same way as the person who has power of attorney. There
hmm
have been some incidents where you have
incidents. No,
that's a tough
Inci-
word. some
Incident
issues. I must just change
issues.
the word issues of patients who,
It's like me and spell check.
I know, exactly. Let me try again.
Completely off. Not even
Right click. Let me
close.
just change a different word.
Anyway, go ahead. I'm
Anyway,
so
sorry,
sorry.
squirreled. When we talk about patients who are in full arrest, or and a family member has power of attorney, and the patient who is
Mm.
in full arrest has a DNR, do not resuscitate, and the patient who has, or in the family that has power of attorney says, I want to work them up. That is again a gray area. So when I looked it up, it says generally the DNR takes precedence over the family's wishes or the power of attorney's wishes. Is that does say it specifically in the state of California that the do not resuscitate takes precedence over the durable power of attorney. Again, there's might be some expiration dates, so that could fall into a gray area, but that's such a small sliver of it. I don't want to like have people be nitpicky and not provide care. But overall, generally, the do not resuscitate takes priority over the family's power of attorney of saying, let's work them up so that we're respecting the patient's wishes.
So what you're saying, Pulse is on scene,
Mhm.
power of attorney is on scene,
Mhm.
and you're saying that the Pulse is, from a legal standpoint, the one that we should endeavor to follow.
Correct, which is not gonna make power of attorney happy, and that's a long, difficult conversation that's gonna be uncomfortable. Yeah. As long as that pulse is, accurate and valid. If it's not valid,
What makes it accurate and valid?
it needs to be signed by a doctor to if there is an end date on there, that it's not past the end date. But we need to make sure that it is completely it's filled out, signed by a doctor, and that the date's within range.
I think that's one of the biggest problems that we have is they're never signed. They're never completely
They're usually
filled
blank,
out
right?
correctly, and they're presenting it to us, and it's inaccurate. So
Yeah, and
that's good to know.
there is that aspect too, like when we talk about hospice patients too, where they're given families given a whole bunch of information and a binder of everything that is what the hospice program is about, and families got to go through it, spouses, even the patient, depending on how lucid they are. And they're supposed to fill that out. Whether they get direction on how to fill it out, what timelines they're supposed to get that filled out, I'm not sure what that looks like. But usually there's a post in there that needs to be completed and signed by a doctor. And there is some time because hospice has a doctor, a nurse, and a social worker that's usually involved with that particular patient. And depending on how often they meet with that doctor, via, FaceTime or, actually in person or, some type of online, they need to kind of get that paperwork filled out as soon as possible. So we tend to see ones that are not completely filled out or not appropriately filled out because something has fallen, at the wayside there.
And so I mean I think that's I was just looking at the exact verbiage and at least for our local protocols, um, a pulse is not valid without signatures. Verbal or telephone orders are acceptable with follow-up signature in the physician by the physician in accordance with the family community policy. There should be a box checked where the authorized healthcare provider discussed the pulsed orders with them.
Yeah.
The tough part where I think we're most likely to run into this, right, is valid DNR is in place, EMS is there, assess the patient's in cardiac arrest, we have a valid pulse, the decision is made, hey, we're going to no further pursue this resuscitation in accordance with the pulse. And family is going, nope, I am
Yeah.
the medical decision maker. I know I void this out. Would you recommend, and I'll kind of give you my thoughts, but would it be worth starting at least a basic resuscitation and getting, base physician on the phone? How do we navigate that? Because I think that's a very sticky situation. Or do we just say we're not doing it? Here's why we're not doing it, and allow the family to start that grieving process now. I mean, is there a
So this is going to sound very social worky, but
oh
I think you could argue for either way. Um, I think the
well, that's
family.
unhelpful.
I know it's very unhelpful,
I think it's more
but
confusing.
I think it's case dependent and how the family is behaving because if you have family members that are starting to get very assertive, even aggressive, um, by doing nothing, does not serve the whole situation as well. Sometimes you're going to have family members that are going to be, and they're going to be emotional. That rightly so. Their family member has passed away. But having that full on conversation of like, hey, this is going against your loved one's wishes. This is what is going to happen. This is what we will have to do, and just be very, systematic in how we explain. Like, we're gonna have to press on their chest, and you might have to get graphic too, and be like, we're gonna break some ribs. We're gonna start an IV and give them medications that ultimately, at this point, is not anything that your loved one wanted. Anything that we are going to do here is not going to be any different that they're going to do at the hospital. So having that kind of conversation, if it's getting aggressive and they are really absolute, then yeah, you kind of have little option. But I think base contact would actually be very beneficial to get, so they can say, yeah, I talked to doctor, and even do it on the speakerphone. Hey, you have a doctor here. This is with the family. Explain everything, and so that there's that little bit of back and forth, so that there's that all encompassing. But just and then being very clear, like your family member is dead. There's nothing that we're going to be able to do, or the hospital's going to do any differently. I don't know. What are your thoughts?
No, I mean, I think so too. I mean, I think these are very quick conversations that have to happen fairly quickly because of the situation itself. I mean,
Yeah.
I think we see it presenting itself in two ways. We see it with a valid pulsed or DNR, and the family wants resuscitation,
Hmm.
or we're on scene with an invalid pulsed or DNR, and the family doesn't want resuscitation.
Yeah.
I certainly think the one where we have the legal backing of not resuscitating. I think that one makes some sense of really pulling the family to the side and explaining this is their signature. They don't want. They are telling you they do not want this.
Correct.
The one where the DNR is invalid, the wishes are there,
Yeah.
but the DNR is invalid. I think that one starting at least a BLS resuscitation, because that's the standard of care for a patient in cardiac arrest, certainly makes some sense. And then getting base on the horn early, especially when family is supportive of, we don't want this.
Yeah.
And you're like, I understand, but this paperwork says that we don't
It's
have a
nothing,
choice at
so
the
we
moment
have
because
to. Yeah.
there's nothing on this piece of paper. And I think in my experience, base has usually been pretty receptive to, we have a DNR, it is improperly filled out, but I've got family here that is requesting no further resuscitation. And for the most part, I haven't run into any specific issues when we're all on that same page. But I mean, I think we need to be prepared for both sides.
Correct.
Valid DNR with a disagreeing family. Thanks, Brad. And we have an invalid DNR with a supportive family, but we need to kind of be prepared for both situations.
Yeah, and I think contacting base would be helpful in both those situations. One, with uh, the active pulse, with the family saying, yes, I want resuscitation, they can help back you up, but also provide just a different level of like understanding for the patient, or for the family, excuse me, of like, this is what's going to happen. And this is what's happening, and why we are saying no. And the other one as well, I have not run into anybody when I've contacted base where they're like, no, you should just work them up and bring them in, like that. I have not seen that. They've been real supportive and
Yeah.
understanding and granting the family's wishes.
Sure. It's really just a matter of making sure we have the legal backing to pursue or not pursue, and making
Hmm.
sure, I mean, at some level it does become CYA, but it's also doing what's right for the patient and the family
Yep.
and the system and so on and so forth.
Yeah, and always do that documentation piece, like document exactly
Yeah.
what it is.
Live or die by documentation.
It'll save you.
I think that's going to be Brad's next episode title,
Ooh.
live or die by
I
documentation.
do like that.
I wish.
We are running out of time here. Any parting thoughts, social worker Pendergraft, before we part ways?
Just, whether they can make their own decisions or not, we're still going to treat everyone like a human, like a person, and with that they have autonomy, so we can respect most of their wishes. If they don't fall into the criteria where they can't make their own medical decisions, whether they have power of attorney or conservatorship, but they're
Sure.
still within that level, they can make, some decisions, and we should give them the power to make decisions. We should not take everything away. And when we talk about competency versus capacity, like even though they can answer all the questions, do they have the right judgment to make those decisions, and that can go either way. So just be mindful of that and creating a level of safety. If we're going, yeah, we're okay with leaving you here. However, we're going to need to have some like level of safety, family members, bystanders, something along so that if anything changes, that issue can be mitigated.
Perfect. Sounds great. Well, with that, we will call it there, and hope everybody has a good evening. And
Don't forget
apparently,
to ask Ken.
Brad has stickers for sale.
Ask Ken.
Other than that, Jalen, appreciate the conversation about capacity and competency and how to handle some of the legal side of it, especially if we're put into a position that we haven't been put in the past. And I think that's about what we got for today. So, Brad, if you got our playoff music, let's get out of here.
Bring up
Yeah,
the
you
mood
guys
a
are
little
both
bit.
a wealth of knowledge. I learned so much from this. So thank you.
Thanks, Brad.
Thanks, Brad.
And our playoff music, there it is.
This thing,
What?
Baby Ken.
Baby
Oh,
Ken.
God.
I'm going to start wearing it right here.
Yeah, totally.
Just Baby Ken. I think that's going to be great.
Yeah. You
Oh,
totally
it's
should.
cut. Oh, okay. Cut. Need that little thing. All
Yeah.
right. Bye.